All right, party people. What we're going to do is we're going to go ahead and get started. So couple of things before I choke myself to death. Before we get going on this. The first being, hopefully you guys get a chance to check your emails today. Dr. Widener sent out an email to everybody, and I just want to echo the words that she said in there about how impressed this past few weeks, I think not just she has been, but all the faculty have been with what you guys are doing and how you're doing it and how you're just going about the day right now. I know there is way too much going on. And despite all of the garbage that's happening right now and the lives we're having to find ourselves in, the fact that you guys are approaching it in a really admirable way, I think is pretty cool to say. And so I just want to echo the words that she said a lot better than how I'm saying it right now. But check out your emails. She said, I think what a lot of us are feeling about how you guys are going about everything right now. So check that out if you get a chance. The other thing that I want to bring up is that there are a handful of you, and when I say a handful of you, I mean 5 of you, who have still not signed your South Carolina DEAs. If you are one of those 5 people, I expect you to have that done by the end of the day tomorrow. If you do not have your DEA signed, you cannot write prescriptions and you cannot practice here at Prisma Health. That is one of the requirements of you as a physician, is that you get your things signed. They are sitting in Ashley's office. Please come by and sign your DEA. It takes 2 seconds to do. But if you're one of those people, please remember to come by and do that. I know some of you have been trying to get in contact with her over the past couple of days and just been missing her, but please make it a point to come by the residency office today or tomorrow and get that done. So without further ado, what we're going to do is we're going to get started with this vulnerable populations talk. This is going to be much worse than what I had planned. And that's just full disclosure for you guys, because this was going to be, before we had to go back to a virtual environment, a kind of panel discussion amongst people. And so it was going to be some of our social workers from Chalk, some of our social workers from the inpatient side of things, some of the people from the forensics team coming and talking, and their social workers and their teams. And so it's going to be a big panel discussion of a bunch of people to talk about what vulnerable populations are, kind of what it means, and to have really kind of a more active thing. This is not going to be as good as that. Just be honest with you guys. To try to do that in a virtual environment is a lot harder to do. We will try to make this as interactive as we can. But you and I both know how well that usually goes over a Zoom call. So we'll move forward with stuff. And just for some of you to know, the reason that this talk is kind of happening is, besides the fact that it's an important thing, is because one of the things that came out in our ACGME survey this year was people wanting to have more exposure and discussion of how to work with vulnerable populations and how to recognize them and really work with diverse and inclusive individuals. And so this is kind of was supposed to be the kickoff to our series this year. So just know that's kind of where all this stuff stems from. Okay. I might be calling a few of you guys out, so just be at the ready to have some discussion if I call on you, and we will go from there. All right. Let me share my screen with you guys here. Let's do this one. All right. There we go. All right. So vulnerable populations, this was adapted from the American Journal of Managed Care. So when we talk about vulnerable populations, a lot of people have a lot of stake in the game. Certainly our patients have a big stake in the game. You guys as providers have a big stake in the game. Our nursing staff, our social workers, kind of some of our more ancillary staff, But another group that has a fairly large stake in the game are actually insurers and insurance companies, because one of the bigger pushes more currently when it comes to reimbursement is to try to think about some of the vulnerable populations, the social determinants of health, the things that we can maybe impact outside of the clinical setting that might actually improve healthcare outcomes. And so this American Journal of Managed Care is actually a publication that is not just for insurers, it's actually for anybody who works with managed care populations, which tend to be more of the Medicaid populations, and trying to think through, okay, well, what are some of the ways that we can impact things to improve outcomes for patients and decrease healthcare utilization. And so that's a big part of it. So when we talk about vulnerable populations, let's see, this is where I'm going to start calling on people. Somebody from, let's see here, NICU. Somebody from NICU. Jake or Scott, I see both of you guys sitting there. What do you two? Give me an idea of what would be a vulnerable population.
How about kids?
Good, kids. Good job, kids. That works. So yeah, so age plays a role. The very young,
Sorry.
very old.
It bogged down. I meant, sorry, kids in the foster system or who have been adopted.
Good. Foster care system. Love that. All right. Let's see. Alyssa A. Sorry. Too many of you.
I would say maybe any children who has complex medical care and needs like certain supplies that other kids don't necessarily need at home.
Absolutely. So people with complex medical needs. All right, Cecilia, give me one. Now that you're getting ready to take a bite.
Any racial or ethnic minorities?
Absolutely. Racial and ethnic minorities are a big one. All right. Oh, Jay has got a baby, so we'll see if she can actually do it or not. Can you give me one?
Babies.
Babies. Yep, absolutely babies. Okay. Milap, you got something?
Have we already said people living below the poverty line?
Good. So those below the poverty line are of lower socioeconomic status. Good. Well, you guys hit most of them. So this paper recognizes 5 big things. And so when we're talking about vulnerable populations, this is kind of in general what we're talking about. So the vulnerable populations are those that have their healthcare issues exacerbated by their social factors. So things that happen outside of the healthcare system that impact how their healthcare is either provided, or their access to healthcare, or the complications that they have from their healthcare, right? So they're at increased risk for both morbidity and mortality compared to the general population. So the big ones are racial and ethnic minorities, the economically disadvantaged, and those with chronic health conditions. And this is kind of the 5 kind of areas that have been kind of identified within this publication. So the young and the old, those with chronic medical illnesses, those with low income or lower socioeconomic status, those of disadvantaged geographic or racial backgrounds, and then a special population that is more frequently or more recently been recognized are our LGBTQ population. And we'll talk about each one of these things and why they're a vulnerable population here in just a couple seconds, okay? And there's a little bit of a video to show you guys too. So we'll talk about all 5 of these things and kind of how they're vulnerable, what they're vulnerable, what kind of things impact them, and why their healthcare is at higher risk for poor outcomes compared to the rest of the population. Okay. All right. So I think the one that is outside of the very young and the very old that you guys that's easiest to recognize are probably the chronically ill and disabled, right? So when you guys hear somebody as being chronically ill or disabled, why do you guys think they're at risk for being a vulnerable population? Some of this is kind of straightforward, no duh, but let's see. Mallory, why do you think somebody that's chronically ill or disabled, why would they be at risk? Why are they a vulnerable population?
Because I think Alyssa mentioned that they have more like healthcare needs as far as like equipment and things like that. And then they also require more care by like whether it's parents or guardians. It takes a lot of like effort to keep them going.
Yeah, you're exactly right. it's a lot for these patients, and everybody's different. The definition of chronically ill and disabled it differs depending on provider, depending on state, depending on insurer, all that kind of stuff. But you're exactly right that part of the whole thing is that there's more that goes into taking care of these young people, right? And because of that, they're at increased risk for what we call fragmented care, right? So disjointed care, fragmented care. It's almost like being in silos, right? That they go from one provider to another provider to another provider, and then they have their home health company, they have their home nurse, they have a bunch of people, cooks in the kettle, so to speak of, that are sometimes managing one thing, sometimes managing other things, and sometimes those things overlap and sometimes they don't. So that fragmentation of care increases their risk and their vulnerability to receive poor healthcare outcomes. So we always need to think about them in terms of how can I impact them a little bit differently, right? What kind of biases am I walking into when I'm taking care of somebody that has chronic medical needs? So somebody in the second year class, if there's many of you, I don't see a lot of you, somebody in the second year class, give me an idea of how your bias might impact you in terms of your interaction with a vulnerable population and something you might need to confront a little bit as you're walking into the room. So I'll give you, go ahead.
When you're talking about being in silos, I find myself being biased based on the rotation I'm on. Like for instance, if you're on an elective rotation and you're walking into a kid with a complex care situation, oftentimes you focus on just your specialty because you're like, well, this is all I'm responsible for. So I'll defer all those questions to the other people. And so that's definitely a bias that I'm sure as people progress into those specialties, as careers carry on. And so that's something that's, as residents, it's difficult to shake because, we're really caring for the whole person, even if we're just studying nephrology for that day.
Yeah. And Scott, so I would ask you then, how does that then translate to maybe a bias that a general practitioner might have? So take that a step further and think a little bit about how would a general practitioner, how would that kind of parlay into somebody who's their primary care doctor, for instance, when they're coming to see you?
Yeah, absolutely. So then at that point, you'd say, well, this is out of my wheelhouse, so I'm just not going to touch this. Or, this is a test that I don't know how to interpret. So you're deferring a lot more. Yeah, absolutely. Or you're assuming that somebody else is going to take care of it, right? Oh, well, you have a GI doctor and they're managing this part of your GI illness. So surely they're managing this other part, right? Or, oh, well, the pulmonologist and the allergist are doing these two things and I'm sure they're talking to each other. And so I don't need to address those issues. And so that's one of the things that we have to think about when it comes to chronically ill and disabled and bring to light a little bit for ourselves is really being open in the conversation and communication about first and foremost, what you do and don't know, and to understand it's okay to not know, but you have to take it a step further and say, I don't know, but this is what I'm going to do to find that out for you or to help you out. And also to understand that there are some times where you think somebody is working on something and maybe they're not. And so you have to be much more kind of frank and blatant with the communication that you're having, not just with the families, but also with the subspecialists, to make sure you're not adding to that fragmentation of care, whether that's being a subspecialist or whether that's being a primary care doctor. Communication is of the utmost importance for the chronically ill and disabled because they are at higher risk for the fragmentation of care. Mallory did a good job of talking about some of the things. They have a lot more needs, right? So they have medical needs, they have durable medical equipment needs, they have nutritional needs, they have different transportation needs. There's a bunch of different needs that people that are chronically ill and disabled have that sometimes people don't recognize, right? And so getting somebody to and from appointments, it's not always the easiest thing if you have somebody who is, for instance, dependent on a wheelchair. If a family doesn't have a lift, if they don't have the use of medical transportation, getting them to appointments can be a big deal. And so thinking about how we coordinate care for them to make sure
they can get to those appointments is of the utmost importance. And whether that's trying to schedule multiple appointments in one area in one day, having more televisits is a great thing that's kind of come out of all this pandemic stuff. And so you have to consider a lot more about things when it comes to chronically ill and disabled. So I'm going to share a little bit of this video of being a parent of a child with medical condition from the University of Michigan. I apologize, University of Michigan, boo, boo, boo. But we're not in football season yet, so I don't have to worry too much about it. But this just kind of gives a perspective of a parent in terms of some of the things that they experience, some of the things that sometimes happen that as a provider, it's hard not to take to heart. But there are reasons why parents kind of do some things that they do related to kids with chronic medical illness. So anyway, here's just a few minutes of her talking.
Here to keep them busy and occupied.
To be a strong and effective advocate without alienating, you have to figure out what your priorities are. Strong and effective is fantastic. Without alienating, that's a bonus. That's a bonus. I've alienated people. I've changed doctors that I thought didn't work well for what I needed for my daughter. I have what I think is the best team of doctors at the U, but that's not by accident. I think it's important for parents to let doctors know that that they know their child, and they're starting to realize, I think, that nobody knows the child better than their parent. And we may not know everything from the medical perspective, but we learn it. We learn it. I think some of us feel like we should have degrees ourselves. And it's important, I think, if we're talking about coordinating services, it is important that we get educated and that you know what you're talking about when you go into these appointments, and to write things down. Sometimes these consultations are so quick. You wait for an hour in the waiting room and the doctor comes in and they're in 3 minutes and they're back out the door. And you're like, if you don't write down your questions and say, wait, don't leave, I have another one. You get home and you're like, darn it, why didn't I ask that? So I think it's important to be organized and to know exactly what your priorities are and what you need, and find the people that can help you accomplish that.
So what did you guys hear there? Carly, what did you hear there and what she was talking about? Tell me what you heard her saying, just in summary, kind of what when she was talking, what kind of things were running through your mind?
You said Carly, right?
Yeah.
It kind of sounded like, she feels, and I understand, like, as a mother, of course, we wouldn't need to feel this way, but with a child with a chronic medical illness, kind of take over and do other parts of care that maybe moms with kids who don't have chronic medical illness don't need to do. And she felt the need to, like, kind of go the extra mile for their kid, maybe because they weren't receiving that from their provider already.
Yeah. So how many of you guys have heard a parent say, well, or heard the term, nobody knows a child better than their parent, or what she was describing of, well, that's fine, that's the medical thing, but I know my kid, right? That's that paternalistic, maternalistic tact that a lot of families with chronic medical illness create for themselves, because they know the one-off of their child and the circumstances that surround their child, and they've developed that as a way of trying to make sure that you understand that I'm here to protect my child first and foremost. They recognize them as vulnerable. They want you to recognize them as vulnerable as well. And so when that doesn't happen, that's when you sometimes get this what she was kind of describing of, I've fired doctors before, I've gone to different providers before. It's because there's not that sense of, hey, you're really understanding where I'm coming from, what I need for my child right now, and creating that symbiotic relationship of taking care of them. And so I hope all of you guys can understand why that sometimes comes out in patients with special medical needs, is because they've had those experiences where people are running in, talking to them for 2 minutes and running back out and not giving them maybe some extra time that they might need. And so opening those dialogues and conversations can certainly help for patients with chronic medical needs. And sometimes you'll find that there are things that come out that you didn't know that they needed, and just having more of a conversation with them, and opening up dialogue. So kids with chronic medical illness, this is going to be the section we spend the most time talking about right now, because they are by far and away our most vulnerable population in pediatrics. Some of these other things are certainly a big portion of it, but I think most of us would recognize those that are chronically ill and disabled as being some of the more vulnerable population within pediatrics. All right, let's see here.
And
No, I don't want you. I want the next slide. There we go. Low income and homeless individuals are another population that that is considered to be a vulnerable population. So those of lower socioeconomic status. And none of these things, while we're talking about these things, none of these things are independent of each other. Many of them actually kind of flow from one to another. And unfortunately, most vulnerable populations have multiple areas of vulnerability. It's not just that they are chronically ill and disabled. It's not just that they are of lower socioeconomic status. It is not just that they are of racial and ethnic minorities. Unfortunately, a lot of times those things all co-occur with each other. And so that's part of the hard part about this is while we might be able to impact one of these areas, if we're not trying to impact all of these areas, we're going to continue to put them at risk. So when we talk about persons of low and lower socioeconomic status, homeless individuals, they have a lower access to care, right? They're less likely to pursue care because they are either uncovered in terms of their medical coverage, and they have less interaction because they can't afford to pay for some of the medical care they provide. Fortunately, most of the time for kids, they are covered underneath the umbrella of Medicaid or Medicaid managed services. The state of South Carolina is a large Medicaid population. So let's see, where is a third-year resident that was at the AAP? Jay is driving, so I can't call on her. Please be careful. Look at the road. Oh, there's Rachel. Okay, good. So Rachel, do you remember like what percentage of the 700,000 people covered by Medicaid in the state of South Carolina, what percentage of them were pediatric? Do you remember?
Oh, I don't think I remember. Sorry.
That's okay. So it's about 70% of them were under Medicaid or Medicaid managed services. So that equals around, I think, 500 and something thousand kids covered by Medicaid and Medicaid managed services. So it's a huge portion of Medicaid in the state of South Carolina are kids. And so we're very fortunate that we have that coverage to offset some of this. Now, not all services are covered, and particularly behavioral health services and some of the things we would love for them to be covered for are less covered. But people of lower socioeconomic status do tend to have more co-occurring conditions, whether they are chronic medical issues, behavioral health issues, substance abuse or depression issues. So a lot of different things because their access to care tends to be lower. And then the other part of that are those that are homeless have a higher incidence of some of these co-occurring conditions, as well as some of the issues related to vulnerability. I was reading this awesome essay by Malcolm Gladwell last night talking about homelessness and how to improve homelessness, and I won't get into it too much, but there are technically two types of homelessness. And so I'll let you guys try to guess which one kids tend to fall into, which bucket. So they're what are called the transient homeless, and they're the chronic homeless. So the chronic people that are chronically homeless are those that spend greater than 75% of a month in a shelter or a non-home setting. The transient homeless typically spend less than a week a month as in a homeless or shelter type situation. So which of those do you think kids typically fall into? More of the chronic homeless or the transient homeless? Anybody?
Transient.
So, transient, there we go. Somebody answered. Got you off the hook. So the transient homeless and that patient population actually is at no worse risk than the general population or lower socioeconomic status for vulnerability index or poor health outcomes. Once they cross that threshold into chronic homelessness, that risk factor actually is amplified quite a bit. So part of the goal for us should be to try to, if people are in that transient homelessness situation, lower socioeconomic status, to make sure we are keeping them out of that chronic homelessness situation. So those are the things that we should be trying to impact for them, whether those are finding more permanent homes, more permanent shelters, more permanent means of living, whatever we can be doing to try to prevent pediatric patients from becoming the chronic homeless, the better off we're able to be. So anyway, and it makes sense that why people that are that chronic homelessness situation are at increased risk, because they're harder to get a hold of. They're harder to have follow up. They have more co-occurring health conditions. They're more exposed to hyper and hypothermia. The elements that we live in put them at risk for poor health outcomes. So definitely a patient population that we need to be assessing and seeing what kind of impact can we actually have for people to improve their means of living and their way of living, so to speak of. Okay, so we'll talk about certain geographic and racial communities. There are patients and pediatric patients that are at risk for poor health outcomes based on where they live and based on their cultural backgrounds and cultural differences. And so this talks a little bit about the Native American population, but what other kind of racial or ethnic groups might you guys think of, generally speaking, or why would, I guess is a better question to ask, why would people of racial and ethnic minorities be at increased risk for poor health outcomes? Let's see here. Let me find somebody I haven't called on yet. Max. Oh, I see Ashley's little head popping in too. So you guys can tag team it.
I think the Hispanic population pretty much comes to mind immediately, especially those that exclusively speak Spanish, or for that matter, anyone that speaks an alternative language other than English. I think there's a lot of disparities there, just frankly, just because of communication with them. I think you miss a lot of what they're going through medically and socially and whatever else you can think about, just in terms of communication. Yeah.
Ashley, you have anything else to add?
Your transient workers and children of your transient workers, I think, would also be at elevated risk, even if they do speak English, especially if they're undocumented. Some of them may not want to come in for fear of that come to light as well.
Yeah, you guys are both exactly right. And so anybody who does not have English as a first language within our country is at increased risk because of exactly what you're talking about. Some of it is because they don't know how to access care sometimes. Sometimes they aren't living in a community that has a trust of the medical system, and they have some fear of deportation, of reporting, of detainment, all those things. So they are less likely to access any public services, let alone medical services, unless they're an emergency. And so people of racial or ethnic minorities that don't have a sense of community. So if there's a smaller community within that geographic site, there's a risk of decreased access to care in those situations because they don't have that social support, social construct, so to speak of. It's oftentimes where in certain communities you'll actually see, and this is fairly common in chalk, all of one racial or ethnic minority comes to one clinic because that's the clinic you go to. So the one that comes to mind for us is we have a fairly large Karen speaking population. I don't know that a lot of other clinics in Columbia are seeing a ton of Karen speaking patients. And so it's one of those things that oftentimes that sense of community actually can be built within your medical system and within your medical clinic. And so part of what we should be doing is reaching out to people of racial and ethnic minorities where we know it's a smaller community of people to make sure they are helping people that they know reach out for care when needed, knowing that there are services available for them to help them, not just from a medical perspective, but from a social construct perspective. And so those are big things to keep in mind. Geographic isolation is certainly a big thing. So if you live in the middle of nowhere, Bamberg, South Carolina, if you've never been to lovely Bamberg, South Carolina, it is a little bit more rural. Dr. Stallworth will tell you that. But if you live in a area where there is less access to care, you're less likely to access care. If there's one clinic available for the entire county region, your ability to make it to that clinic or go to that clinic might be limited because of the number of slots available to be seen. And so there are some geographic isolation issues that can make people more vulnerable to things. One of the things that we try to do here to improve that access to care, especially with our subspecialists, are going out and doing some of those outreach clinics, right? That's a way to improve access to care. That's a way to improve things for vulnerable populations who may not be able to make an hour-and-a-half drive to Columbia. But I can make a 15-minute drive to Sumter to see my cardiologist. And so that's one way to try to improve access to care, is by decreasing that geographic isolation that some families have and some families experience. It's very well documented that there are racial and ethnic minorities that receive lower quality care because of a variety of different things, whether that's the availability of resources to the clinics that they're being seen at, the funding to those clinics. The Native American population is certainly the one that is most well documented and known about, but a lot of other racial and ethnic minorities in addition do have a poor access to care and poor healthcare outcomes related to that. So again, something to think a little bit about is the interactions that you're having with patients and how those interactions might parlay into how their care is being perceived, how their care is going to be delivered, and what kind of things you can do to impact those things, okay? And so something to keep in mind. All right, so the last group we'll talk about here, and we'll hopefully give you guys a little bit of time back today, are our LGBTQ community. As you guys can see here in the numbers 1 in 5, so 20% of the LGBTQ population have reported facing fear of discrimination when they're seeking medical care, which is very, very similar to those of different racial and ethnic backgrounds. Because of that, their vulnerability lies in increased risk of psychiatric disorders, substance abuse disorders, and rates of suicide, suicidal ideation and suicide attempts. And so the LGBTQ community, and this is one of the things that I think I'm very thankful for, again, that we in pediatrics recognize the patient population and how we can impact them and how we can be inclusive of the LGBTQ community at a very young age. I thought it was really, really cool the article that Nisi picked for Journal Club to talk a little bit about this, and the fact that we have some things being done in our endocrinology clinic with the LGBTQ community and those with gender dysphoria and things that they're trying to kind of improve the lives of kids a little bit in an early stage. Unfortunately, the thing that you guys don't get educated enough about, and certainly people of my era didn't get educated enough about, was about how to provide culturally competent and knowledgeable care to the LGBTQ community. So for those of you that were at the SEAAP meeting, we had the discussion or the talk by the adolescent medicine provider where he talked about how he just introduces himself, right? He walks into the room and says, "Hi, I'm Dr. Such and Such. I use my pronouns are he, and I just want to know what you go by and what pronouns you prefer." Like that was it was a very unassuming way of having a conversation, but it was just opening a conversation for the adolescents that he provides care for to say, "Hey, this is a safe space. Like this is who I am. Want to know who you are, and then we can have some conversation about it." And it's a way of introducing yourself and trying to dispel barriers, break down barriers that have built up over time. And unfortunately, geographically, again, sometimes these stereotypes, these things are harder to break. And I think we can all recognize that sometimes in the South, things are a little bit slower to move in many ways. And the things that our patient population maybe sometimes has to overcome is different in places that may be a little bit more diverse, so to speak of. But really, it's one of those things that we need to be opening up these conversations. We need to be having these conversations. We need to be acknowledging things that our LGBTQ population is at risk for, right? So talking to them about their mental health, about bullying that's happening, happening, about just where they're at in life and the feelings that they're feeling, and making sure we're connecting them to resources early on to help them with those things. Not saying they're wrong, not saying they're crazy, not saying that there's something wrong with them, but the feelings that they're feeling are feelings we need to help you manage, because they're not right. They're not right for you as a population. They're not right for anybody as a population. And helping to understand that mental health affects us all, regardless of our gender, regardless of our sexual identities, regardless of any of that stuff, can sometimes help that discussion to be had. But really, really big, growing vulnerable population that we're starting to see more and more in kids. And so something to keep in mind whenever you're walking into your chalk appointments with patients, to have those open discussions, to find out more about them and not make assumptions just because we're walking in the room. And sometimes it's a harder thing to do, especially with parents in the room, about whether or not families want to disclose things, or kids want to disclose things or talk to you about things or not. So. All right, and then the last group is the very young. So I don't need to spend too much time talking about this, because you guys know all of these reasons why they're more vulnerable. This is very, very, very simply written about that they have developing organs, low immunity, spend more time outdoors, maybe, I guess. They're supposed to spend more time outdoors, if they actually do or not. The things that we, I think, deal with every single day help us to understand why kids are vulnerable and why we need to advocate for them more. Hopefully you guys have seen some of the stuff here recently in the media or on social media about the amazing advocacy network that has been developed just in about a week and a half's time period for kids, and trying to impact the legislature and helping to kind of take the proviso out of the current budget about funding for schools that decide to mandate mask mandates. That's something that has been very grassroots, and something that pediatricians, I think here, we started it before we got to SCAAP, are really working hard to make sure that schools aren't going to either be not funded or have harsh penalties put upon them if they decide to ask patients to mask. They're trying to make sure that we're protecting all kids as much as possible, and not just small subsets of populations. And so that's the kind of thing that we as pediatricians do, right? We advocate for kids, we speak up for kids, we do things for kids because they can't do it themselves. And that's the cool part about pediatrics is we get to do that. Most of the time, older people aren't speaking up for adults. Adults can speak up for themselves is usually the motto or the frame of thought. And so the very young are definitely a vulnerable population because they don't have a seat at the table, so to speak of, and we have to be their seat at the table, right? And it's our job to do that. So something that I know you guys all live, and I don't need to spend too much time talking about. So that's all I got. Like I said, this was meant to be a much more robust discussion. If we would have had the social workers around, I'm sure they would have had a lot more to add. But what more do you guys want to talk about? What questions do you guys have? And I don't have answers. I don't necessarily have all the answers, but I'm happy to have some more discussion about it, about vulnerable populations. Are there patients that you guys think of outside of this framework of these 5 that might be more vulnerable that we need to be recognizing more? Are there patients you think we do a good job with it? Do you think there's groups where we don't do a good job with it? Let's just have some discussion by whoever would like to, if anybody.
Other than what you've just talked about, I think we haven't talked about like foster care system. It's going through a lot of different foster homes, not having that consistent parental figure. So the kids have to be the liaison for themselves to their medical care, just because otherwise it's like the DHEC officer who may not know everything.
Yeah, you're exactly right, Ashley. And they may bounce from clinic to clinic, right? Because it's not like they have a consistent medical home when that happens, right? You go into a different foster family who lives on a different side of town who decides, nope, this is where your doctor is now. and now you've fragmented that care, and you've changed that things. Now we can impact that a little bit, hopefully by reaching out and saying, if we know that somebody's in a foster care system, advocating for them to continue to come to this clinic if at all possible, or at least having some conversations with our fellow pediatricians when we're able to. So there are ways to hopefully impact that, but it takes more work, right? And that's the key to all of this, is in order to improve the lives of these vulnerable populations, it takes more work. And when you're already busy, when you're already exhausted, when you have 10 other notes you have to write, it's harder to do that work. But it can be really, really meaningful. And it doesn't have to just be you. It takes a team to impact these people and impact this population. So it takes a team of nurses. It takes a team of social workers. It takes a team of LPNs and schedulers and physicians and subspecialists. It's not just a one-person job. If you approach it as a one-person job, you're not going to be able to help as many people as you would like to. And so I think that's the other thing to think about is you don't have to do all this. You can reach out for help, reach out for resources, reach out to somebody to say, hey, like, can you help me with this? Or do you know what I do for this? Because that sometimes is all that's really needed. Any other thoughts, comments, questions? Okay. Well, y'all try to have a good day. It looks like Alyssa A. and Mallory are enjoying the outside. Jaya is too. Y'all be good. Stay safe. We'll see you soon. Okay. Bye, guys.